On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Understanding Enhanced Barrier Precautions. My name is Amanda Bennett, and I will be your moderator for this program. We welcome any comments or questions. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar. Joanne Adkins is a registered nurse and infection prevention advisor for the Patient Safety Authority. Ms. Adkins is board certified in infection control and epidemiology and is a fellow of the Association for Professionals in Infection Control and Epidemiology. Ms. Adkins is a 2019 recipient of APIC's Heroes of Infection Prevention Award for Education. She is a member of the Association for Professionals in Infection Control and Prevention and has served on the Member Services Committee, the Sigma Theta Tau International Nurses Honor Society, and the Pennsylvania Association Directors of Nursing Administration.
Thank you, Amanda. Good afternoon, everyone. Thank you for joining us on this webinar for Understanding Enhanced Barrier Precautions. Our objectives for today are to review the organisms requiring the implementation of enhanced barrier precautions, describe the precautions and when to institute them, and list the high-contact resident care activities requiring the use of enhanced barrier precautions and the PPE. So March 20th of 2024. On March 20th, CMS released their memo that required long-term care facilities to implement enhanced barrier precautions. It's regulation listed at the top 2408. Enhanced barrier precautions in nursing homes to prevent the spread of multidrug-resistant organisms. Enhanced barrier precautions is the use of PPE for residents with targeted organisms, chronic wounds, or indwelling medical devices to be used during high-contact resident care. They also issued new guidance to the state surveyors and long-term care facilities on the use of these precautions that align with nationally accepted standards. These recommendations now include the use of EBP or enhanced barrier precautions for residents with chronic wounds or indwelling medical devices during high contact care, regardless of their multi-drug resistant status. And this new guidance is being incorporated into the Infection Prevention and Control Regulation F880. And if you are not doing enhanced barrier precautions, you will be cited under F880. So to understand enhanced barrier precautions, the difference between them and contact precautions and standard precautions and how to implement them, I'm going to review some of the goals of infection prevention because it always goes back to the basics. Infection prevention has three principal goals: protect the resident, protect everyone else who enters your facility, and accomplish these two goals in as cost-effective manner as possible. But there are some key concepts when it comes to infection prevention within long-term care. We know that your residents are at increased risk of infection for many reasons. Congregate living, where they are living together very closely. Staffing turnover puts them at risk because you may be getting new staff that is not well versed or educated on infection prevention. The dependence on unlicensed caregivers, because there is a big gap between the training that nurses receive and the training that CNAs receive. Elderly people have poor immune responses. Their immune system is wearing out, for lack of a better way to put it, and they don't mount the immune response to fight infection. And another reason for high risk is the increased use of invasive devices and acuity in long-term care facilities. But another problem is that by regulation, CMS requires you to provide a home-like environment and person-centered care. You need to use least restrictive environment, but they also expect a safe environment, free from infection, free from exposure to communicable diseases, but residents still being provided the opportunity to engage in social activities for their psychosocial well-being. So it does make it to be a challenge and quite the balancing act. So one of the things that is important in infection prevention and long-term care is the importance of early recognition. Early detection of infectious disease plays a crucial role in the treatment and prevention of infection within your facility. There's many advantages to early detection. It can lead to better treatment outcomes as the disease may be in its initial stages and make it more responsive to treatment. Early detection can also prevent the disease from progressing, which reduces the risk of complications and improves long-term health for your resident. It also allows for early implementation of precautions to help prevent the transmission and limit spread of that infection or disease. Early recognition reduces the risk of transmission of infection between residents, healthcare workers, and others within your facility. But for early recognition to happen, you need surveillance. Constant surveillance is necessary to identify potential infections and help control transmission of disease or infection. So how do we go about doing that? Well, you want to minimize the exposure, and how we minimize the exposure is through some steps that I know you have heard many times before. We want to break the chain of transmission, do adequate hand hygiene, make sure all staff are following standard precautions, implement transmission-based precautions when necessary, and utilize enhanced barrier precautions to help prevent that transmission. So to review those quickly, this is your chain of transmission. The picture on your screen represents the cycle or chain of transmission of an infection, and this is the path that pathogens follow to cause infection. They're spread from one person to another through this common series of events that we call the chain of transmission. If you can break that chain at any point in the cycle, you will prevent that pathogen from infecting more people. So you have an infectious agent, and we're going to say influenza, and the reservoir of that infectious agent is the people who currently are carrying the flu virus. They may not know they have it yet, they haven't become symptomatic, but they're still infectious. There has to be a portal of exit, and where this portal of exit comes into play in enhanced barrier precautions, it could be the stool that can't be contained by the diapers, or when you're diapering or toiletering a resident, that could be the portal of exit. But when we're talking influenza, we're talking droplet spread. And that is the mode of transmission. The mode of transmission is how that pathogen is passed, whether it's direct or indirect contact, whether it's droplet or airborne spread, whether it's contact through broken skin, whether it's from devices or you touching an inanimate object, but how it's spread, and then how it gains entry into the new host. What is its portal of entry? Mucous membranes, respiratory tract, broken skin, invasive devices. But the host must be susceptible. And that can be anyone. But it's more likely to be a susceptible host in the very young or the very old, people with weakened immune system, people who had recent surgery, or diabetes, or indwelling devices such as PICC lines or catheters makes them more susceptible for infection. But if you can break that cycle at any point, then you will not have transmission of disease. So you break the chain and stop the spread. And here are links to two really good tools available from APIC for healthcare facilities to do education, both for staff and also for residents and families on how to break the chain of transmission and what it is. Another thing we do to protect our residents is hand hygiene. Hand hygiene is the most effective way to prevent the spread of infection. And I know that we continually talk about hand hygiene. It's one of the easiest measures we can take and your staff can take, and it is also sometimes one of the ones that is overlooked. We just started our symposiums for long-term care last week, and in speaking with some of you, when you're monitoring your hand hygiene by secret shoppers, people were surprised just how poor the compliance level was. Please make sure as IPs, you are monitoring your staff on hand hygiene compliance and monitoring them on PPE usage and compliance with precautions. So when do you perform hand hygiene? Before you have any contact with the resident, because we live in an environment that has totally infested with many, many, many pathogens. So you need to clean your hands before you have contact with the resident. I always tell people to clean them as they're entering the room because you don't know what you may have touched in the hallway that will pick up germs. Please make sure the staff know they must clean their hands before putting on gloves. We know what bacteria like. They like a warm, moist, dark environment. And we also know that your hands before hand hygiene carry thousands and thousands and thousands of germs. If you don't clean them and decrease the amount of germs on your hands, when you slide them into the glove, you have put those germs in the perfect incubator. It's warm, it's moist, and it's dark, and they will proliferate. So make sure staff know that they need to clean their hands before they put on their gloves and when they take them off. Also, hand hygiene before inserting or manipulating any invasive device, and this includes emptying a Foley catheter. Make sure your staff perform hand hygiene and put their gloves on, because even though that system is closed, when they open it to empty it, then you have an open pathway for germs to enter. We also do hand hygiene after contact with the resident's skin or any objects within their environment. Any contact with secretions, body fluids, excretions, wounds, contaminated items. And after removing gloves. Gloves are a wonderful barrier, but you can contaminate your hands taking them off, or the gloves may not be, they may have some tiny microscopic holes that could allow pathogen to enter. Fingernails, take a look at your facility policy. It is your hand hygiene policy is to follow one of the experts, which may be CDC or World Health. CDC recommends that for direct caregivers, the fingernails are short, no more than 1/4 of an inch, and no artificial nails or overlays, because there have been correlation with outbreaks related to those artificial nails. But make sure your staff know your hand hygiene policy. Make sure you're monitoring for compliance and auditing, and make sure they all know what the expectation is. When we talk about contact precautions, enhanced barrier precautions, and multi-drug resistant organisms, we talk about colonization and infection. We know the contact precautions create a lot of challenges for nursing home facilities. You're trying to balance the use of PPE and room restriction that's required with contact precautions against the least restrictive environment that's required by regulation. Any active infection with a multi-drug resistant organism, if it is one that is like a skin infection and you can't contain this drainage, they must be in contact precautions. People who are no longer actively infected can still carry that multi-drug resistant organism in their body, and that's called colonization. And colonization will persist for a very long time and can lead to silent transmission of that pathogen to someone else. Another issue with these multi-drug resistant organisms is we're getting more and more resistant organisms at all times, and they're developing novel mechanisms of resistance, which makes it much more difficult to treat them. This next slide I put in because my associate here, Christine, always talks about the iceberg, and it's a really nice visualization of colonization. The tip of the iceberg you can see are your residents in your facility that you know are either actively infected or colonized with a certain organism. And I'm just going to use MRSA, methicillin-resistant Staph aureus, because we're all familiar with that. So the people you know are colonized or actively infected are the iceberg you can see above the waterline. But because we know how easily these pathogens can be transmitted, the people who may be colonized below the waterline is a much higher number of residents, which is why precautions are so important. So what are the resident characteristics that go along with being colonized or infected with a multi-drug resistant organism? Well, your residents are at increased risk because of poor immune systems. They're also at increased risk because of conjugate living. Studies have shown that more than 50% of long-term care residents are colonized with a multi-drug resistant organism. And the reason why that's so important is because we know that an infection caused by those multi-drug resistant organisms carry increased costs to treat, are harder to treat because you have limited treatment options. They really impact the health and safety of your residents. They carry a much higher morbidity rate and a higher mortality rate. So what do we do to address these multi-drug resistant colonizations or infections? Well, that's where our precautions come in. We have standard precautions, transmission-based precautions, and enhanced barrier precautions. For this webinar, we're focusing in on enhanced barrier precautions, but because we're talking multi-drug resistance and most of the mode of transmission is contact, we're also going to review standard and contact precautions with you. Standard precautions is the primary strategy to prevent transmission among residents and staff. They're a set of infection control practices that are used to prevent transmission of diseases acquired by contact with blood, body fluid, non-intact skin, and mucous membranes. Standard precautions came into being in 1991 when OSHA released their bloodborne pathogen standards in response to the AIDS crisis. All residents are in standard precautions at all times. And what staff have to realize, and I know I see when I go into facilities, just because there is not a precaution sign hanging on that door, if you have a resident who is coughing and sneezing and hacking, standard precautions say you need to protect yourself and wear a mask and eye protection. Same as if you're going in to deal with a resident who has a draining wound, and prior to enhanced barrier precautions, we didn't have enhanced barrier precautions. Standard precautions still said with that draining wound, because of the chance of being contaminated, gowns and gloves were needed. So remember, all residents are in standard precautions at all times. So standard precautions are the minimum infection prevention measure that apply to resident care, regardless of whether we have a confirmed or suspected infection in that resident. These were designed to protect healthcare personnel and prevent spread among your residents. And like I'm going to say again, please remember all residents are in standard precautions at all times. It's hand hygiene, use of PPE, safe handling of your contaminated equipment and the patient's environment, respiratory hygiene and cough etiquette, and safe injection practices. So just teach your staff to dress for the occasion. If they think they're going to think about the job they're going to do or the task, and if there's a chance they're going to be splashed, splattered, or contaminated by that job, then they need to wear PPE. So those are standard precautions. And before enhanced barrier precautions, if the organisms needed to be isolated, we would go to contact precautions. But when we talk multi-drug resistant organisms, like I said before, you need that balance. Prevent the disease transmission, but don't isolate them to the fact that there are consequences for their psychosocial well-being. So you need to look at each of your residents for risk factors and use the least restrictive approach. Do they have wounds? Do they have indwelling devices? Are they able to contain their secretions or excretions? Will they follow instruction? Let's say you have someone with draining diabetic ulcers, but they have dementia and they continually pull the dressing off and then the secretions go all over the place. That resident, you can't contain their secretions. They would need contact precautions. What is their behavior? Will they allow you to assist them? Will they keep the dressings on or the diapers on? And do they have good personal hygiene? So one thing we talk about when we talk multi-drug resistance is cohorting or precautions. Cohorting is when you group residents that are infected or colonized with the same pathogen or infectious agent together to confine their care to one area. That prevents contact with other susceptible individuals. Another part of cohorting applies to your staff, your healthcare personnel. During an outbreak, dedicate staff to that outbreak area so they are only caring for the people that have that infection to help prevent that transmission. We saw this with COVID when you made your red zone, when you had one hallway or one area that was blocked off and staff were dedicated to that area so that decreased the risk of transmission. So here's your residents at increased risk for developing multi-drug resistant colonization or infection. The use of invasive medical devices, which we see much more frequently in long-term care. You're seeing more central lines. You're seeing dialysis catheters. You're getting people very quickly post-op. They're at increased risk with inappropriate use of antibiotics, which leads to the development of resistance. Poor hand hygiene from staff or from the residents themselves can help spread germs. Ineffective environmental cleaning. Make sure your environmental services know how to clean effectively. Then you have the resident challenges. The acuity of residents in long-term care is much, much higher than it was 10 years ago. So you're getting much more sick residents with more lines. And you have the mentation challenges where they can't follow directions. They will not leave their dressings in place. You may not be able to keep them in a private room. And then what I call their stuff. All of the items they keep within the rooms that they brought with them from home or people give them. All that stuff that sits around makes it extremely difficult for your staff to clean. Congregate living puts them at increased risk because they're all living very closely together within the facility. Staffing turnover leads to increased risk because you may not have staff being new that are as well educated in infection prevention or control. Dependence on unlicensed caregivers, and then the blunted immune responses of the elderly. So contact precaution, and this sign is available from the CDC. Contact precautions are used for multi-drug resistant organisms, Clostridioides difficile, norovirus, scabies, and shingles in immunocompromised residents and vesicles that cannot be covered. All residents with an MDRO with when there is acute diarrhea, draining wounds, or other sites of secretions or excretions that cannot be contained or covered need to be in contact precautions because they will contaminate the environment. We also put residents in contact precautions if you have ongoing transmission, whether it's documented or just suspected of that organism. And then contact precautions are also required depending on the infection or the organism. All of you should have Appendix A, the type and duration of precautions, readily available to help you in your role as infection preventionist. This is on the CDC's website, and I have a link at the end of this presentation. This is where you can look it up by infection type, by disease type, by organism, to see what type of precautions are required. So if you do have to put a resident into contact precautions, it's hand hygiene before donning and after doffing gloves. You need gloves and gowns for any entry into that room. The equipment is dedicated to the room, such as blood pressure cuffs. If it is equipment you cannot dedicate to the room, if it's shared equipment, such as a glucometer, you cannot dedicate it to the room, then that equipment must be cleaned and thoroughly disinfected before coming out of that room to go to someone else. These residents are restricted to the rooms except for medically necessary care. And medically necessary care is not going to the dining area or going to activities. It would have to be medically necessary, such as if they had to leave to go to dialysis or they had to go for additional testing. And then environmental services need to really prioritize cleaning and clean more frequently with a focus on high-touch care. So because there was such a difference between contact precautions and standard precautions, this is where enhanced barrier precautions come into play. So I want to take, whoops, hit the wrong button there. I want to do a quick poll with you. Are you using enhanced barrier precautions in your facility? Please take a moment to fill out the poll. You're using them facility-wide. You already have them implemented. They're working well. We are partially implemented. Maybe you're only using them on a couple of the units. You're having discussions and just starting to develop the process for enhanced barrier precautions, or you have not started working on them yet. So please take a few moments to answer that survey for me. It helps my colleagues and I see where our facilities are and where we need to really offer more education. So in 2019, CDC released what they called enhanced barrier precautions. This was a new approach that recommended glove and gown use for residents during specific high contact activities associated with potential multi-drug resistance transmission. It's a strategy in nursing home to interrupt the spread of novel or targeted MDROs. So please take a few minutes to answer that. And then Shelley, I'm going to ask you to close the poll and we'll see what we have.
Okay, so it looks like 33% said EVP are used facility-wide, 25% partially implemented, and then 38% they're having discussions and developing the processes, and then 4% have not started working, but then there's also people that answered in the chat box as well.
All right, thanks, Shelley. So it looks like most of you are at least in the process of implementing enhanced barrier precautions. So we're going to go through enhanced barrier precautions. They're an infection control recommendation or intervention designed to reduce transmission of multi-drug resistance. They initially were released in 2019 just for a targeted group of organisms, and then in 2021, after more research was done and based on expert opinion, a broader use of enhanced barrier precautions was released, including pathogens that affect every nursing home in this country, including Staph aureus. So they were released in 2019, updated in 2021, and now in 2024, they have become mandatory. So this sign is available on the CDC website. It is an enhanced barrier precautions sign. And the rationale for enhanced barrier precautions is the fact that many nursing home residents are colonized with a multi-drug resistant organism, and we don't know it. You don't screen everyone who comes into your nursing home. You may be notified from a hospital that somebody is either infected or colonized with certain multi-drug resistant organisms, but remember that iceberg. There are many more that we do not know about. Enhanced barrier precautions helps reduce the spread of multi-drug resistance without isolating your residents for long periods of time. These residents can leave their rooms. They can participate in activities if they're under enhanced barrier precautions. They are not restricted to their rooms. These precautions are not near as restricted as contact precautions. But there have been studies that have come out that show using enhanced barrier precautions can effectively reduce the spread of multi-drug resistance within your facility. So they're recommended for residents that are infected or colonized with a targeted organism or MDRO where contact precautions don't apply. These are the residents that have a draining wound that we can contain. These are residents that will leave that dressing in place. So they don't need to be in contact precautions, but we still need to protect everyone else. It's also used for residents with an indwelling medical device or with wounds. It's an approach for glove and gown use based on the resident's risk factors and the type of care being provided, rather than being solely based on their multi-drug resistant status, especially for your residents that are at risk for developing or acquiring a multi-drug resistant organism, the people with wounds or devices. So here are the high contact care activities that enhanced barrier precautions are required for. Dressing the resident, bathing and showering them, transferring them from bed to chair or chair to bed, providing their hygiene, changing their linens because we know linens are highly contaminated, changing briefs or assisting with toileting, caring for these invasive devices, your central lines, your Foley catheters, feeding tubes, trachs, that sort of thing. Caring for wounds. And when we define a wound, it's any skin opening that requires some type of dressing. These are the organisms that we're looking at, your pan-resistant organisms that are highly, highly, highly resistant to antibiotics. Your carbapenemase producing or carbapenemase resistant Pseudomonas, Enterobacterales, Acineta ballani, Candida auris, MRSA, your ESBL producing organisms, your vancomycin resistant Enterococcus, multi-drug resistant Pseudomonas, and drug resistant Streptococcus pneumoniae. So I have people who have asked me over the past month, why are we doing this? What's the rationale for it? Well, the rationale for using enhanced barrier precautions is that contact precautions create challenges for nursing home facilities when you're trying to get that balance between using PPE and room restriction with quality of life. We only implement contact precautions when the residents are infected with an MDRO or for other organisms such as C. difficile, norovirus, scabies. We know that colonization can persist for long periods of time and result in silent transmission, which is one of the rationale for using these precautions. And we also know that we have a lot of organisms that are pan-resistant becoming more resistant rapidly or have very novel mechanisms of resistance. And as they emerge, we are using enhanced barrier precautions to help prevent that spread. So this is a nice table that the CDC has on their website that you might want to share with your staff. It's a very clear piece to educate them on what precautions they would need, who it applies to, what PPE is used, and when it is used. So for standard precautions, as I said before, all residents in standard precautions at all times, and it's for any exposure to blood or body fluids or contaminated environmental surfaces. And the PPE required depends on your anticipated exposure. But those residents do not stay in the rooms because that's all your residents. Enhanced barrier precautions, residents who either are infected or colonized with one of those MDROs when contact precautions do not apply. If you can't contain the drainage, they're in contact precautions. Any resident with wounds or indwelling medical devices, and it's during the high contact activities, the dressing, the bathing, the transferring, the linen change that I went on before. This is when you would need the gloves and gowns. If you're just walking in to talk to them, or if somebody's walking in just to give them meds that's not going to be high contact, then no, you don't need the gloves and gowns. Contact precautions, on the other hand, if someone has acute diarrhea, draining wounds, or other secretions or excretions that you can't cover or contain, they're in contact precautions. Residents with other infections, norovirus, C. diff, scabies, they also go into contact precautions. And then you need the PPE to enter that room. And it's gloves and gowns before you enter the room, and then they come off before you leave with hand hygiene. And those residents must stay in the rooms when they are in contact precautions. They cannot be out and about. I have had people ask me about posting the signage for enhanced barrier precautions because it will be a HIPAA violation. This is coming directly from the CDC. Posting of signage does not violate HIPAA. The signs are intended to signal to individuals entering the room the specific actions to be taken to protect themselves and the resident. To do this effectively, the sign needs to contain information about the type of precaution and the recommended PPE to be worn. It does not contain the diagnosis or the reason for the precaution, which is why it does not violate HIPAA. The generic signs that I have seen in facilities that say "speak to the nurse" are not adequate for any type of precautions. People need to know at the time of room entry what PPE they need. But all the signage do not include the diagnosis or reason for precautions, such as the pathogen that they may be infected with. If that information was on the sign, then yes, it would violate HIPAA. But just posting signage that says what is needed to protect yourself or protect the resident is not a HIPAA violation. So considerations for applying enhanced barrier precautions. You need to make sure that your staff receives education and training, not only on what enhanced barrier precautions are and when they are applied, but also competencies. Do they know how to put on, don and doff the PPE appropriately? And are they being monitored to make sure they are doing that? Signage. You need to have a method to identify your residents who have wounds, indwelling devices, and potential MDROs. And then you have to have policies and procedures developed for enhanced barrier precautions. Within your policies, make sure it indicates the signage that requires your PPE, where you will place your PPE, and it is recommended it be placed outside the room, and that is recommended by both CDC and CMS. Another part of your policy is hand hygiene and PPE disposal. There are cost considerations that go along with EBP because you will be using more gloves and gowns. But that cost would be offset by what an infection would cost if your resident would get infected with a multidrug-resistant organism. One of the things you may want to look at is ways to optimize your PPE supply. Bundle multiple care activities for the resident together. Don't go in to do one item, have staff come out, and go back in 10 minutes later to do another piece of care. Also look for potential overuse of PPE. Are there times when PPE is being used that it may not be necessary? And one thing some facilities have considered is washable cloth isolation gowns that are laundered according to healthcare facility standards. Another big piece of this is people are wondering how will they dispose of all this PPE. Well, one thing people need to remember is not all personal protective equipment needs to go in biohazard bags. The Bloodborne Pathogen Standard of 1991 defined what is regulated medical waste that requires biohazard disposal. Regulated waste is waste that has liquid or semi-liquid blood or other infectious materials that can be released from that item if compressed. These are the items that really have a lot of secretions and blood on them. If it's just an isolation gown that has no visible waste or secretions or excretions on them, they can go into general trash because general trash is a biohazard. It's not in a red bag because of body fluids, but it is also handled in a certain way. Contaminated sharps are part of medical waste, regulated medical waste, as is microbiological or pathological waste. But most PPE used during regular resident care is not regulated waste and can be discarded in the regular trash. But it's important to have the appropriate disposal container available for staff to remove the PPE inside the room. So what I did and what my colleagues did is we've gotten many questions on enhanced barrier precautions since the CMS memo came out on the 20th. I've compiled some of the more frequent ones, and I'm going to go through those now. One thing I wanted to say about the gowns and gloves, because this comes up all the time, we do not reuse them. We do not reuse gowns. They are used and disposed of, or if they're a cloth gown, put into the laundry. You don't hang it inside the door to reuse later because it is contaminated and people will become contaminated putting it on. So the first question, and I copied here right from the APIC listserv for long-term care because the CDC actually responded to this one. There have been many, many questions. Can the PPE for enhanced barrier precautions be stored inside the resident room? There are potential issues doing that. The PPE will become contaminated, and you will have decreased compliance for use because it's not visible. What is on the screen is the CDC's response, and their response was no. Due to the risk of contamination and potential transmission, they do not recommend the PPE is inside the room. They said either a PPE card outside the doorway or maybe an over-the-door hanging PPE compartment. But I know on the APIC listserv, there was someone who had decided to store their PPE within the bathroom. Not one of me, not myself or my colleagues will ever tell you that is okay. That PPE will be contaminated. Your bathroom is a very high area of contamination in any resident room. That is not okay. The PPE has to be, it has to be visible, and it has to be at the entry to the room so that people see it and use it. Another question that I received is what was considered a medical device. This is a device that goes from the outside into the resident's body. It provides a direct pathway for pathogens to enter the body. These are your trachs. These are your central lines, your dialysis catheters, peg tubes, a nephrostomy tube, things like that. I also got asked if a urostomy was an indwelling urinary device. No, it is not. There is no device present. If it's a new colostomy or urostomy, once that wound has healed, it is no longer an area of risk. And then I was asked, in relation to wounds, what's considered a definition? These would be your surgical wounds. You may be someone who gets total hips or total knees for low-level rehab after surgery. Until that wound heals, that is a wound that would require EVP. Chronic wounds, your pressure ulcers, your diabetic ulcers, unhealed surgical wounds, venous stasis ulcers. Those type of things are the wounds in relation to EVP. Someone who gets a tiny skin tear that you can cover with a Band-Aid, that would not be someone that would require enhanced barrier precautions. One of the questions we receive is, what is the difference between enhanced barrier precaution and standard precautions? Enhanced barrier precautions is a bridge between standard precautions and contact precautions. You are providing an extra level of protection using the gloves and gowns to prevent workers from picking up organisms and transmitting them, and also to protect residents from that transmission. But it does not require a resident to be confined to the room. Contact precautions require gloves and gowns to enter the room. Enhanced barrier precautions, if you are going to be performing an at-risk activity, the up close and personal, the bathing, the toileting, the linen changes, then you need the gloves and gowns. When should a resident have contact precautions instead of enhanced barrier precautions? If they have secretions or excretions that you can't contain. If you cannot contain that drainage within a dressing, they have to be in contact precautions. Another question we get is, I have a resident who does not have a history of a multidrug-resistant organism, but does have a Foley, a medical device. Do I still need to put them on enhanced barrier precautions? Yes, you do. And I do know, depending on the facility and the amount of acuity, you will have a lot of residents that will require enhanced barrier precautions. Another question was, are enhanced barrier precautions required for residents with C. difficile infection or scabies? No, they are in contact precautions. We only use enhanced barrier precautions for multidrug-resistant organisms when contact does not apply. And then somebody asked me if hospitals are doing this. No, enhanced barrier precautions are specific to long-term care. Even the long-term acute care hospitals or assisted living communities are not recommended to do enhanced barrier precautions. This is for long-term care where you're doing up close and personal, high-risk activities, but then want to allow your residents to have the freedom to be outside the room and attend dining or activities or other things. There are people who have asked, what is the evidence that these are effective at preventing transmission? There are many studies that have shown they reduce transmission. You can pull them up off the CDC website. I also have links at the end of this to the evidence. But these precautions are evidence-based best practice, and now they are a regulation. I was asked, how did the CDC decide what activities to use enhanced barrier precautions? And the way they decided is they sent people in and did hundreds of observations of care in long-term care facilities. And these people then evaluated what the different care items were and what was the potential for transmission of pathogen. And that's how they came up with their high-risk list. People will ask, do they need to be, enhanced barrier precaution residents need to be in a private room? We want your private rooms to be prioritized for acute infections or your communicable diseases, your influenza, your C. diff. We want that to be for there. If you do have private rooms available, then you may want to implement that for your enhanced barrier precautions, but they can stay in a room with someone else who is not in enhanced barrier precautions. We just want you to keep spatial separation, which is at least 3 feet between the beds, to reduce the opportunity that you're sharing any items. Sometimes places will partially pull the curtain as a nice reminder to people to keep that barrier in there. If somebody is in enhanced barrier precautions, it's the same as contact precautions. With reusable equipment, it needs to be cleaned and disinfected before coming out. And you also want to clean these rooms like you would do a special precaution room, a contact precaution room. You want to hit the high touch areas. You want to make sure they're cleaned more frequently. Make sure that your environmental services are being audited also on how well they're cleaning, to make sure that they are doing effective cleaning and they're hitting the right high touch areas. Oh, I just saw one question there I have to answer. The urostomies and colostomies, if they are healed, they are not considered a wound and they are not considered an invasive device, and that's directly off the CDC's website. Enhanced barrier precautions focus on glove and gown use and not your other important control measures. We want to stop the transmission from that up close and personal care. All other infection prevention practices are critical for all residents at all times, the environmental cleaning and that sort of thing. How long do people stay in enhanced barrier precautions? Duration of their stay. The only time that may change is if you have a resident who you had an enhanced barrier precautions because of a wound or an invasive device, and that wound or device, the wound heals or the device comes out, then you could take them out of enhanced barrier precautions. And then the last question I had up here is, can a resident come off EBP if we screen them and they test negative for an MDRO? And the CDC was pretty adamant on that. No. Colonization is prolonged, we know that, and there's always the potential for follow-up testing to have a false negative result. So at that point in time, the CDC does not recommend routine retesting for residents with a history of colonization irritation or infection, or discontinuing of enhanced barrier precaution after a subsequent negative test because it could be a false result. So in quick summary, before we get to see what the most frequent questions being asked were, infection prevention is everyone's responsibility, and residents in your facilities are at increased risk for infection because of the congregant living and the staff turnover and the poor immune responses that we discussed earlier. CMS requires long-term care to provide a home-like environment with person-centered care, but they also require you to provide a safe resident environment for all residents, free of infection, free from exposure to communicable disease, but have the opportunity to engage in social activities. So leadership involvement is essential. They need to be involved with your enhanced barrier precaution implementation. Remember, we use transmission-based precautions for residents with known or suspected infections or syndromes that are at increased risk for transmission when we can't contain that drainage. Enhanced barrier precautions are for the high-risk activities as defined, but the residents are not confined to their rooms, and enhanced barrier precautions only apply to long-term care facilities. So there are links on the next couple slides from the CDC. They have a pocket guide you can give your staff. They have observation tools to help you monitor precautions. They have letters developed that you can use for your residents and families or your staff or leadership on the importance of enhanced barrier precautions. I gave you the link on this slide to Appendix A, which is the type and duration of precautions. And here are the links to their posters for enhanced barrier precautions that you may want to take a look at and use within your facility. So I know that the chat box was burning up. I could see it scrolling through. So I'm going to open this up to my colleagues who have been manning the chat box for me. What questions were asked the most frequently?
Joanne, would you please provide clarity on the question regarding new urostomies and new colostomies and the change in practice once those are healed?
Okay. When they are first developed, when they have the initial surgery that gives them a urostomy or a colostomy, that is a wound that would fall under enhanced barrier precautions. And until that wound was totally healed, that resident would stay under enhanced barrier precautions. Your residents who have had colostomies or urostomies for years, that is not an open wound. That is not an invasive device that goes from outside the body into the body. So at that point in time, that no longer falls under a wound or an invasive device that would require enhanced barrier precautions. Now, that being said, if you're going in there to irrigate that colostomy and you know that there's usually a lot of drainage and you have difficulty containing that, standard precautions fall into play, and that person doing that irrigation needs gloves and gown.
Joanne, there continues to be questions regarding feeding tubes, indwelling Foley's, suprapubic catheters, nephrostomy tubes. Do these need, these residents qualify for enhanced barrier precautions?
Yes, they are considered a risk factor. It is a device going from outside the body into the body.
Joanne, we're also getting a lot of questions about where signage should be placed. The CMS guidance does say that you can use discretion, but it says that they may be placed near or outside the resident's room. So not saying inside the room, I believe is how we have talked and discussed that they need to be outside the room so you are not contaminating yourself while getting those things, and that signage is visible when you're entering the room.
Correct. The signage needs to be visible. CDC their recommendation is the signage is outside the room, same as it is for any other precaution.
Joanne, an additional question has popped up a few times. Does a resident have the right to refuse enhanced barrier precautions?
I'm going to ask all my colleagues to weigh in. My personal response on that is no. Just as they cannot refuse, the resident cannot refuse contact precautions or airborne precautions or droplet precautions, because as IPs, our responsibility is to protect everyone within that facility. And enhanced barrier precautions are not only protecting residents at risk, it's also preventing transmission from people who are colonized or infected with one that we can contain drainage. My personal opinion, and I will be honest, I have not seen that anywhere, but as an IP, my opinion is no. They would need to be enhanced barrier precautions.
I agree with that, Joanne. This is no longer an option. It is a federal regulation that the facilities need to follow.
I echo what Joanne and Amanda have shared here. I would also advocate for resident education. This is a piece of the resident safety program, and at the end of the day, we're trying to keep all individuals that are in a long-term care home safe. So providing education regarding best practice, et cetera, is invaluable when you're undergoing this change. We do not encourage PPE to be placed inside a resident's room. The intent of PPE is to put the personal protective equipment on before you enter the room so that you are protected from the time that you enter and have that extra barrier to prevent you from being contaminated with schmutz that's from in the room, whether they're enhanced or contact droplet, et cetera.
That's correct. I see the one that's here. Do housekeepers need gloves and gowns when cleaning the room of a resident on EBP? Absolutely, because they are going to be in contact with that contaminated environment.
I'm seeing a lot of questions as well about defining the length of time for a wound when we're talking about a chronic wound.
The way it is defined, what I have read on the CDC, is when it is healed over.
I think what makes it require enhanced barrier precautions, like they have not specified staging as far as the chronic wounds, what's included or not included.
No, they have not defined staging. The only thing they have defined when you look on the CDC's website is a wound that is very minimal, like the one I said, a skin tear that can be covered with a Band-Aid. It's not a chronic wound. It doesn't need enhanced barrier precautions, but any of your pressure injuries, whether they are stage 1, 2, 3, or 4, will not heal within a few days. They are then at that point in time chronic wounds. So they would need enhanced barrier precautions.
There are also questions. Go ahead. I was going to say you need to think about the cycle of infection, and an open wound is a source for schmutz to get in and then potentially cause a much more invasive infection. So if they have an open wound, this is an open area of skin that could be potentially contaminated with organisms from you or from the environment, and that is what we are trying to avoid by the use of enhanced barrier precautions. Again, up close and personal contact with the resident. If you're going into the room just to do small tasks like deliver the mail, deliver water, etc., you don't need to wear a gown and glove every time you go in that room. It's for that intimate, close contact.
What I'm going to do, because there was so many questions, is we're going to compile a list of your questions with the answers and also resources for those answers. And then Shelley will distribute them to the attendees so you have the evidence to go along with why we answered the way we did.
Can I just, if people want to say, I just wanted to specify the one other thing that keeps coming up is about having the PPE outside of the room, which for me would be a non-negotiable, but someone brought up if you can have a few isolation carts as opposed to one outside of every door when you're concerned about, congestion. I think, in my opinion, that could be reasonable as long as they're still easily accessible. I'm not sure how the other IPs would feel about that.
I agree.
I agree with that, Amanda. As long as the signage is there at the room entry that they know they need it, as if the PPE is accessible within that hallway, that should be okay. It's not going to become contaminated like it would be in the room or, God forbid, the bathroom.
I think it's like any other activity that you're doing with residents. You're prioritizing and determining what is needed to complete a task in a room. So if you go into a room and learn that the resident requires a complete bed change, then you go get the supplies that you need, and that includes your personal protective equipment.
I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixell at shmixell@pa.gov. This concludes our webinar.